Hello everyone. Today we will be discussing about the acute renal failure, or also known as the acute kidney injury. So this acute renal failure are the main scenario that you will find in a patient managing in the hospital. The most of the patient that you are managing in the hospital, mainly in the ICU and giving even in the critical care units where there will be the burden of other drugs and antibiotics. In that case, you will find that your patient has gone into renal shutdown, gone into acute renal failure, and that is acute renal failure. Okay, so what is that? What is actually, look, this is the condition which you will be which you will be encounter in every portion of your life, mainly while managing your critically ill patient. So when you are going to manage a patient, and while managing you are giving a lot of offending drugs, there are a lot of other comorbidities, and that has led to the renal shutdown. So you need to understand what is acute renal failure, and then will manage accordingly, because acute renal failure is a reversible condition and we can take back the patient in his normal kidney function status if you diagnose properly, if you can able to understand what are the cause, and if you manage properly. Okay, so let's move forward. So what is acute renal failure? Acute renal failure is the abrupt decline in the renal function as measured by, which what will be measured? Measured by the increased creatinine on blood urea nitrogen. So suddenly a kidney function has been declined, and that will be seen, that will be measured by increased creatinine and blood urea nitrogen, or there will be oliguria or anemia. There is absence of decrease in urine or absence of urine. Okay. So that can be divided into three parts. That is, according to the cause, we can divide into three parts. That is pre-renal azotemia, means kidney is there, and before kidney there is something damaged, and that has led to a renal shutdown. That has led to a renal failure. Then renal cause, there is something that has damaged the renal parts and leads to the renal failure. And the post-renal, that is not in the kidney problem, but there is the post to the kidney. The post to the kidney are ureter, bladder, urethra. If there is any problem that has been obstruction and caused the backward pressure and caused the compression on the kidney and caused the atrophy and damage of your cortex and medulla, then that is post-renal. Okay, so then we will discuss about what are the consequences of the renal failure and how can we diagnose, that is pre-renal, intrinsic or post-renal. Okay, so in pre-renal azotemia, that as I have mentioned, that is before the kidney. It's not in the damage of the kidney, it is before the kidney. So what is the before the kidney? Before the kidney we supply the blood to the kidney. So if there is any reason, any cause that has led to the decrease in the blood supply to the kidney, that is decrease in renal blood flow, that will lead because of hypotension, then that will lead to the decrease in GFR. And since there is a decrease in GFR, there is hypotension, there is decrease in GFR. Now kidney, our body has automatic mechanism to control everything, to correct everything. Body will always try to correct everything. Okay, so since there is a problem, now there is undergoing hypotension, generalized hypotension in your body, and you are finding decrease in GFR, what kidney will be supposed to do? Kidney will try to retain everything that it passes through, to conserve the volume, to retain the volume, to gain the volume. Okay, so what it will do? It will, since there is a decreased blood flow, hypotension, decreased GFR, they will try to retain everything to conserve the volume. And so there will be reabsorption, there will be high reabsorption of sodium, all the material that goes into kidney, sodium, water, blood urea nitrogen, everything. So what will be the finding? Osmolarity will be high because there is a low volume in your blood, ADH will be secreted. Okay, so every water will be reabsorbed from the collecting ducts and tubules, and your urine osmolarity will be raised. Okay, so you understand that kidney urine sodium, since they are trying to conserve everything, now sodium will be less than 20 milliequivalent per liter in the urine. The fraction of excreted sodium in the urine, since now kidney had to reabsorb everything, this FeNA, this is the fraction of the sodium that is excreted in the urine, and it will be less than 1%, because kidney has to work for the body, it has to reabsorb everything that is going through it, and it will reabsorb the sodium all available. Okay, the most possible. and then the serum bond and creatinine ratio. As creatinine is not reabsorbed in our kidney, that is only secreted, so we measure is as our GFR, okay, and compare with inulin and GFR. So creatinine will be not be affected by the kidney damage, it will be excreted, but blood urea nitrogen will be reabsorbed. Nitrogen and urea will be reabsorbed more and more from the kidney, and since this is reabsorbed, now this level is high in your body, and because of that your serum bond and creatinine ratio will be increased, since nitrogen and urea component are more in your blood, so this will be increased. So if you have understood this renal azotemia, then you have understood this table as well, and you will be able to diagnose accordingly. Okay, now let's move to the other part, that is the intrinsic one. Okay, now what is intrinsic renal failure? Intrinsic renal failure is damage to the kidney part. Now there is the kidney problem. Okay, so kidney problem can be, why there is a kidney problem? Kidney problem is due to acute tubular necrosis. We'll talk about this. That acute tubular necrosis is, this is not we are talking about acute renal acidosis. That is the acidosis part. But this is, we are talking about necrosis. That certain part of your tubule has got necrode and had been sloughed off. So that part of kidney is not, that part of your nephron is not working. That has actually dead and necrode and sloughed off. So the causes of acute tubular necrosis include ischemia and lot of offending drugs. We'll discuss in detail. Okay, so acute tubular necrosis, one of the cause. Then ischemia or toxin. I have already mentioned that ischemic region, due to ischemia there will be necrosis, and toxin include toxins as well as the drugs. Then okay, and let's come on to the glomerulonephritis. Glomerulonephritis, the main two part, that is rapid progressive glomerulonephritis or hemolytic and hemolytic uremic syndrome. These are responsible for acute renal failure as well. And acute interstitial nephritis. Again, interstitial nephritis, acute interstitial nephritis are due to the drug which we use, that are the heparin, and they cause peeing of your eosinophil. Mainly, we'll talk about penicillin, methicillin. If you remember, then that was taken out from the market because this acute interstitial nephritis, the patient start to pee eosinophils, eosinophilic cast. So these are the damage to the kidney part, and since there is a damage to the kidney part, there is intrinsic renal failure. Okay, these all are, this actually acute tubular necrosis, ischemia, toxin, acute interstitial nephritis, these are actually reversible because the stem cell is intact, and in that case it can be, if we manage the offending condition, then that will be, it will be reversible. Okay, so how can we diagnose here? We can diagnose intrinsic renal failure. So there is a damage in the portion of the kidney. Since there is a damage in the portion of the kidney, that part of the kidney is unable to function. What was the function of the kidney? Kidney function was to reabsorb the all useful material that was secreted in the kidney that is useful for the body. Okay, there was other function as well, that excretion of the harmful substances, formation of the urine, acid-base balance, water balance, etc., etc. But the main thing was to reabsorb the material that was necessary for the body. So this kidney has unable to do that. I feel because of their intrinsic damage to the kidney. And since there is intrinsic damage to the kidney, what will be the osmolarity? Osmolarity, suppose you remember the one part of your table is not working. So there will be always less than 350, because if DCT and collecting tubule has been necroed off, there is no water reabsorption property, and since there is no water reabsorption property, then water in the content in the urine will be high, and that will be the osmolarity will be low. Okay, which you can say it will equal to your normal body osmolarity. Okay, then comes to the sodium part. Sodium part, when we comes to the kidney tubules, if certain part is damaged, now sodium is not absorbed. If sodium is not absorbed, then what will happen? It will excrete it into the urine. So urine content of the sodium will be high rather than 40. Okay, again come with the fraction excreted of sodium. What will be the fraction of the excreted sodium? Since that's the same, you can again, the part of the tubules is damaged, and if it is damaged, now it cannot be absorbed. Okay, so it will not absorb, then extra amount of the sodium will be excreted out. So sodium excreted in the urine will be high, and it will be greater than 2%. Okay, then comes to the serum and bond and creatinine ratio. Since kidney is damaged, that part is damaged, urea and nitrogen substance are not being absorbed. Since not being absorbed, it will be excreted in the kidney, in the urine, and since it's excreted in the urine, now contained in the serum. We are talking about the serum. Serum will measure the serum bond, and serum bond, this creatinine doesn't get affected, but bond is excreted more. It is not reabsorbed, so it is excreted. Since it is excreted, the serum concentration will be less, and bond serum creatinine ratio will be less. So if you understand the real scenario, if you think about it, then you will understand how to differentiate it. And if you understand how to differentiate it, then this will be the feature presented in your scenario while managing your patient in the actual daily life. And even in your board question, you will have this scenario and you can manage it. Okay, so this you have understood pre-renal table. This is also intrinsic renal table, and the one thing I will mention that in acute tubular necrosis there is loss of aware necrotic material that goes into the renal tubule. Renal tubule will be blocked and it will cause backward pressure, backflow. GFR will be decreased, and that how it's work. And since this condition will be arise. Okay, there is one more point that I would like to include is that if you have not seen my lecture of renal cast, then go and see, because that is very important to understand. Here the tubule, you see the renal epithelium is locked up. So anything that gets locked out, RBC, WBC more increase, that get deposit over the cast, and cast is named. If RBC gets deposit, RBC cast, WBC goes, WBC cast in pyelonephritis we have talked about. Same like if in the epithelial is locked up, it will go and deposit over the cast and known as the epithelial cast. Okay, even in this condition, there will be a granular cast. So intrinsic renal failure, you will have the granular epithelial cast, and which will be a diagnostic point, which will be a lead in the question or they will ask about it. Okay, so you have understood intrinsic renal failure as well. Okay, now post-renal azotemia. Post-renal azotemia is there is nothing in the kidney damage, there is nothing in the previous blood supply is okay, kidney is okay, but after kidney there is obstruction in the bilateral ureter, a stone is there, or in the bladder there is a stone that is blocking the urethral sphincter, or there is in the urethra there is the stone. So anyway, when there is a bilateral or if there is a other condition like there will be stone, I talk, there will be benign prostatic hyperplasia, neoplasia, congenital anomaly. If there is a bilateral obstruction, then both kidney will develop hydronephrosis, there will be a backward pressure, there will be a pressure on the cortex and medulla, there will get atrophy, and there will be damage like intrinsic renal failure. If it is a mild urine is passes, then there is not much problem. But if there is a severe form, then it will obviously factor the kidney and secondary kidney damage occur. And if the kidney damage has already presented, patient will always present with renal failure only if the kidney damage has occurred, and that we are talking about. So all the features will be like intrinsic renal failure, that your osmolarity will be less, your kidney content of your urine content of the sodium will be high, your fraction of sodium excretion will be high. Okay, actually in my case it will be less than 1%, but if we are talking about renal failure, in severe case there will be same as the intrinsic renal failure, it is 2%, and even the bond serum creatinine ratio it will vary actually. So this is what we are talking about: acute renal failure, acute decline in renal function. You see the creatinine getting high and high and high. You diagnosed as acute renal failure. You are saying that acute kidney injury has occurred. Now you have to find out what are the cause of anything, and you will manage accordingly. Okay. Now you have to understand one more thing is that what are the this consequences of the renal failure. Actually, see, consequences, this is the what we have talked about the acute renal failure. There is another term like chronic renal failure, and chronic renal failure is the chronic condition that develops over a long period of time, and there will be the predisposing condition, that is there will be the cause like hypertension, diabetes. Okay, these are the diabetes mellitus, congenital anomaly that has been taken the long time to develop, to damage your kidney slowly and it will be damaged. That is known as chronic renal failure. And according to the GFR, we will calculate it in the 1 to 5 stages. Okay, so that is chronic renal failure. Now, what are the consequences of the renal failure? If renal failure has gone, if renal is shut down due to acute or chronic, now what is the consequences? Consequences are like mad hunger. I will talk about it. Okay, So MA is metabolic acidosis. So one of the component of your renal failure is metabolic acidosis, and we have talked detail about metabolic acidosis in the acid base lecture. You go there and discuss about it. Okay, now comes to the D4 is the dyslipidemia. So there will be a metabolic acidosis, there will be dyslipidemia. H4 is there will be hyperkalemia. Hyperkalemia. U4 will be uremic syndrome. That is uremia, and which will leads to the other condition like there will be nausea and anorexia, pericarditis, then hysterexis, encephalopathy, platelet dysfunction. These all are the feature of your uremic. Okay, so there will be in uremia there will be increase in BUN, that is blood urea nitrogen, and in that case it will leads to nausea, vomiting, pericarditis, hysterexis, encephalopathy, platelet dysfunction. Uremic feature will be there, and obviously there will be increase in uric acid. Okay. Then comes to the HUN, and 4 is the sodium and water reabsorption. So there will be sodium and water reabsorption will be retention will be there. So if there is retention, so if there water is more in the body, what will happen? There will development of hypertension, there will development of heart failure, and these are the consequences of your increased sodium and water retention. Okay, like they will also develop pulmonary edema. So what are the consequences of sodium and water retention? Heart failure, hypertension is the main, then heart failure and pulmonary. Okay, then there will be the, we are talking about the G for the, there will be the growth retardation and developmental delay. Okay, then their lift is EN. So E and N, HUNGER. So E and R. Okay, so E for erythropoietin failure, and that is anemia. Okay, anemia, and R for is that is renal osteodystrophy. Renal osteodystrophy. So what are the consequences? And in this renal osteodystrophy, there will be a hypercalcemia, hypovitamin D, and hyperphosphatemia, and that leads to your bone damage. Okay, bone peristitial thinning will occur, and that we'll discuss actually. So you need to understand one main thing is that there is a formula to understand what are the consequences of your renal failure, and the major consequences of your renal failure we can remember as a formula: MAD hunger, MA4 metabolic acidosis, D4 dyslipidemia, H4 your hyperkalemia, and which is this hyperkalemia and metabolic acidosis is very dangerous. Okay, so metabolic acidosis, dyslipidemia, hyperkalemia, U for uremia is also very dangerous, and it requires urgent if there is the pericardial involvement or anywhere you need to get for dialysis. Even hyperkalemia refractory needs to dialysis. Okay, then sodium water retention, that will lead to your hypertension, heart failure, and again pulmonary edema. Then it comes to the G for the growth retardation, and there will be the developmental delay, immediate providing failure, there will be the anemia, and there will be the renal osteodystrophy. Then these are the consequences of your renal failure. I hope these are clear. This is very important to understand for your board as well as your daily life. This will you will have patient actually when you goes to the ICU, and when you be able to manage your patient in critical ill patient, then you will encounter this situation in lot of time in your life. Okay, and so you need to have a clear idea about it, and then we can proceed further. Thank you.